we begin a three-part sequence on Buddhist perspectives on death and dying. This first lecture works through Andrew McCormick's article, Buddhist Ethics and End-of-Life Care Decisions, which is written for medical social workers, bioethicists, and palliative care providers. McCormick's goal is practical. How do you navigate end-of-life decisions with Buddhist patients when Buddhism has no central authority, no codified bioethics, and enormous internal diversity? The title of this lecture, The Mindful Balance, captures the tension he identifies. Buddhism neither clings to life nor seeks death, but tries to find a mindful middle path through the dying process. Context: the U.S. Buddhist population has grown to 3 to 4 million, with about 800,000 Euro-American converts. Buddhism developed long before modern life support technology and lacks a centralized bioethical authority. Notice the two columns. Asian immigrants tend to remain in their home tradition and may integrate indigenous customs. Euro-American converts are eclectic, often mixing traditions. This diversity is the first thing a clinician needs to understand. 3 concepts before we can discuss ethics. Samsara, the continual cycle of rebirths and the suffering that comes with it. Karma, the natural consequence of actions, the state of mind at death and karmic merit earned determine the next rebirth. This is why end-of-life decisions carry such weight. Nirvana, the exit from the cycle. Rebirth as a human is extremely fortunate, because only in human form can one attain enlightenment. A good death positions you for a higher rebirth. This slide sets up the fundamental clash between the Western and Buddhist views of death. The Western clinical view: death is a single, catastrophic point in time. It is a biological failure to be fought off via aggressive medical intervention. The timeline is a sharp cut. The Buddhist view: death is an elongated interval, a transitional state. It is an opportunity to be mindfully experienced and used for inner wisdom. Stonington, whom you will read next, describes a national program in Thailand that reframed the end of life this way. And here is the ethical crux: clinging to a life that has reached its natural end hinders spiritual progress. Buddhism says it is wrong to deny death and cling to life, but equally wrong to deny life and seek death. The mindful balance sits between those two errors. McCormick identifies a spectrum across Buddhist traditions. Theravada clings to the Pali Canon, prioritizes literal interpretation, takes ahimsa, non-harming, as the guiding principle. Mahayana and Tibetan rely on commentary and master practitioners, with karuna, compassion, as the guiding principle. They allow personal opinion and flexibility if intention is pure. This matters clinically. A Theravada family may feel withdrawing life support violates the precept against killing. A Mahayana family may feel compassion requires reducing suffering, even if it hastens death. Same decision, different ethical registers. When a Buddhist needs to test an ethical opinion, McCormick identifies 4 concentric authorities. The innermost circle is scripture, what is directly written in the texts. The next ring, what would be in conformity with scripture, even if not explicitly stated. The third, the tradition of commentary, rational interpretations by later masters like Buddhaghosa or Santideva. The outermost, personal opinion, based on study of the other 3. The critical point for bioethics: modern medical dilemmas, ventilators, feeding tubes, organ transplants, did not exist when these texts were written. So clinical decisions almost always fall in the outer rings, where flexibility and personal judgment operate. The bioethics perimeter must be reached with clear minds and pure intentions, what Buddhism calls skillful means, or upaya. 3 definitions of death and their Buddhist implications. Whole brain death, loss of all brain function. Some Buddhists doubt the testing. Autonomic functions continuing outside the brain may imply the life faculty persists. Higher brain death, loss of consciousness while brainstem functions remain. Meyer argues this best fits Buddhist scripture, since human life is valued for its capacity to attain nirvana, the state of cessation, a profound meditative trance where physiology suspends and there is an appearance of death, but the life faculty remains, like a fire covered by ashes. A meditating person who appears dead may not be dead at all. Organ donation splits along the same traditional lines. The strict Theravada interpretation: if the life faculty is not fully extinguished, as in some brain death scenarios, organ procurement could violate the precept against killing. The compassionate Mahayana interpretation, Sogyal Rinpoche, states unequivocally that masters he has consulted consider organ donation an extremely positive action stemming from genuine compassion. The generosity accumulates good karma. Dilgo Khyentse goes even further. Organs may be removed before the heart stops if there is a clear, compassionate wish to donate. For clinicians, never assume a Buddhist patient's position on donation. Confirm the dying person's wishes directly or through family, and be prepared for the full range of opinions. Follow the decision tree. Is tube feeding providing nourishment or prolonging the dying process? Keown's Theravada position. Tube feeding is a human need. Withdrawing it violates the precept against killing. But clinical evidence shows tube feeding does not prolong survival or prevent bed sores and advanced dementia. Before tube feeding existed in the 1950s, losing the ability to eat was simply how people died. And the process produces natural opioids and pain relief. The clinical takeaway: returning a patient to a natural dying process to reduce suffering is religiously legitimate if undertaken with pure compassion. Buddhism prohibits deliberate destruction of life, but explicitly rejects the duty to preserve life at all costs. This slide unpacks why. The illusion of control, seeking to prolong life beyond its natural span through elaborate technology, arises from delusion, moha, and excessive attachment, trishna. Keown says this directly. The burden of intervention. Sogyal Rinpoche warns that life-sustaining treatment that merely prolongs dying may kindle unnecessary grasping, anger, and frustration, exactly the mental states that produce bad karma and a troubled rebirth. There is no obligation to connect patients to machines simply to keep them alive, no requirement to treat subsequent complications like pneumonia with antibiotics. Futile treatment need not be offered. Voluntary cessation of eating. Buddhaghosa documents this as acceptable for a terminally ill person who accepts death as inevitable, an exercise of mindful will. Physician aid in dying and euthanasia, strictly prohibited by the third Parajita, the rule banning suicide, assisting suicide, and encouraging death. The Mahayana exception. A minority view argues that with pure compassion and skillful means, even suicide could theoretically be accepted. But Florida himself concedes that acting with absolutely no trace of the three poisons is almost impossible in practice. This slide synthesizes everything into a single reference matrix. Each row is an intervention. Each column is a tradition. Read across. Organ donation is high risk for violating ahimsa in Theravada, but highly praised as selfless karuna in Mahayana. Withdrawing life support is viewed as an omission of care, or as taking life by Theravada, but accepted by Mahayana, to prevent futile grasping and suffering. Assisted dying is strictly prohibited across the board, with only theoretical Mahayana exceptions for pure upaya. Hospice and palliative care are encouraged by everyone. It is the one area of consensus. This matrix is your clinical reference tool. When you encounter a Buddhist patient, you do not need to know their school. You need to know where they fall on each row. Buddhist medical ethics is fundamentally intentionist. Intention matters almost as much as the action itself. But intention must pass through the three poisons filter: passion, aggression, ignorance. If a decision flows from these, it is unskillful, regardless of outcome. The pure path, selfless compassion, runs underneath. If the decision flows entirely from karuna, with no self-interest, even a precept violation becomes defensible. The action becomes skillful means upaya. Barnhart's key insight: Buddhism is less about how to behave than what to care about. Family members often experience acute guilt, fearing their decisions will cause the patient a bad rebirth, for example, becoming a hungry ghost. Kong Suan and Chai Pech document this in Thailand. Krishna finds similar patterns in Singapore. The balance on this slide is the key insight. Bad karma is a natural result of unskillful action, not a divine punishment for breaking a rule. Pure compassion acts as a counterweight. Good intentions can mitigate violations of precepts if one acts with more consideration for others than for oneself. Social workers can help ease guilt by acknowledging the precept against harming, while reminding families that reducing suffering through compassionate action also carries karmic weight. 3 practical guidelines from McCormick for clinical encounters. First, do not interrogate patients about formal denominational affiliations. Instead, assess their personal framework for merit and suffering. The key inquiry is, what does a peaceful death look like to you? Use this to transition the conversation away from aggressive interventions toward mindful acceptance. Second, ask how compassion guides their family's decisions. This opens the door to discussing withdrawal of life support without triggering guilt about the precept against killing. Third, the provider's role. Healthcare providers encounter the suffering of others as an opportunity to acquire wisdom. Buddhism teaches humility in the face of death, honesty about our own beliefs, and compassion when working with families making impossible decisions. Now, this is where we begin to connect the three readings in this unit. McCormick gives us the ethical framework, the precepts, the traditions, the tension between ahimsa and karuna. But what does this look like on the ground, in actual clinical encounters? In the next lecture, we turn to Scott Stonington's ethnography from northern Thailand and meet Arirat, a woman dying of pancreatic cancer who refuses morphine because she needs to study her tumor. Her tumor, she says, is a karma master, a sentient being from her past that has come forward to resolve a karmic debt. Stonington shows us how families choreograph the deathbed itself, assembling moral objects, managing spirits, performing forgiveness ceremonies, to produce what they consider a good death. Then, in the third lecture, we turn to Tenzin Namdul's work among Tibetan refugees in southern India and meet Pema, a young woman declared brain dead by a neurologist, but diagnosed as conscious and alive by a Tibetan doctor using pulse reading. Pema recovers fully. Namdul uses this case to expose a fundamental clash between brain-centered and consciousness-centered definitions of death, and introduces us to the 6 bardos, the transitional states that make death, for Tibetan Buddhists, not an endpoint but a luminous continuum. So think of these 3 readings as concentric circles. McCormick gives us the ethical principles, Stonington shows us the lived practice in Thailand, and Namdul takes us into the Tibetan model, where death itself becomes a technology for spiritual transformation. We will build outward from this foundation.